But remember that blood flowing through a tube, or any fluid flowing through a tube, has some resistance to flow. Okay, so blood in a blood vessel doesn't flow through there without some resistance to its flow. The smaller the blood vessel, the more resistance there is to its flow. But that's not the only thing that affects resistance to flow. So here are the things that affect resistance to flow. Vessel length. The longer a vessel is, the more resistance to flow there is. So if you took a short piece of half-inch garden hose, maybe a foot long, got your mouth full of water, and you blew through that tube, you could blow water out the end with some pressure. But if you increase the length of that hose to maybe 3 feet, 2 feet even, you filled your mouth with water, and you tried to blow and make a spurt out the end, is it going to spurt out the way it did out of that shorter length? No. And why not? You didn't change the diameter of the tube. You didn't change any other feature of the tube except its length. All right? Because on the way it's going to have more friction. Where does that friction develop? Along the walls, along the outside. This is why people who gain weight sometimes have an increase in blood pressure. Because that extra tissue has to have blood supply, doesn't it? So that's extra length of vessels, isn't it? So one of the things that people with hypertension can do if they're overweight is lose weight, and oftentimes their blood pressure will respond by coming down. All right, viscosity just refers to the so-called thickness of the solution. So the thicker a solution, the slower it flows. You know, syrup flows slower than water, doesn't it? Okay, so blood is actually thicker than water by about 5 times. Turbulence. So if in this tube, instead of a straight tube we had, let's say we had a tube that had kinks in it. Is that going to increase the resistance to flow? Yes, it is. So anything that creates turbulence. So if you've got an atherosclerotic plaque that's growing into a vessel, you've impeded the flow of that blood somewhat. It's got to get over that hump, you know. So that would be increasing turbulence. But the biggie is this one right here, vessel diameter. Vessel diameter is the most important factor playing on resistance. And by the way, when we're talking about resistance to flow, we're talking essentially about peripheral resistance, meaning resistance in the tiny arteries, well away from the heart, like the arterioles. So vessel diameter is the greatest determinant of resistance. Now, this was proved by a fellow named Pasquale, an Italian, way back. He had a rather complicated mathematical formula that demonstrated this. If we simplify Pasquale's law, we can express it as this formula right here. Resistance is equal to 1 over the 4th power of the radius of the vessel. Now on page 6 of your notes, in the middle, I talk about diameter. In the middle of page 6, under resistance, in your notes, wherever diameter is, change it to radius. Now here is an example of application of Pasquale's law. Again, here's our premise right here. That vessel diameter is the greatest resistance, the greatest determinant of resistance to blood flow. Now, so if we take an arteriole, a small artery, with a radius of 1 millimeter, and we apply this simplified formula right here, we come out with a radius of 1. I mean a resistance of 1.
What did you say changed to radius?
Diameter.
Diameter. Wherever the word diameter
okay.
appears in the middle of page 6 under resistance, change it to radius.
Okay.
It doesn't matter. Look, radius is just half the diameter.
Right.
Yeah.
So, I mean, we're still talking about diameter. But I'm showing you that you can apply a mathematical formula to this to illustrate how changing the diameter of a vessel will change resistance. All right, so if we start with this right here. Now let's say that we double the radius from 1 millimeter to 2 millimeters, and we apply this same formula. We come out with this number. Well, this number is a lot less than 1, isn't it? In fact, it's 16 times less than 1. So you see how much, just by doubling the radius, we've decreased the resistance by a factor of 16. On the other hand, if we decrease the radius from 1 millimeter to a half a millimeter, we increase the resistance by a factor of 16. In other words, the resistance in this vessel is 16 times greater than the resistance in this vessel. And we didn't change it very much, did we? If you just look at the comparative numbers here, but look at the changes out here. So again, the point is, vessel diameter is the greatest determinant of resistance to blood flow. All right, now looking at this chart right here, which part of the vascular system has the greatest surface area? It's this part right in here, right? Where is the greatest resistance to flow? It's this part right in here, isn't it?
Mm-hmm.
The velocity of flow slows way down right in here. That's because of resistance. Because you're going through very small vessels right here. Now, just while we got this up right here, I'll come back to this later. Notice the velocity of flow in the vena cava here.
Mm-hmm.
As we come out of capillaries into small veins and then bigger veins and finally into the vena cava, we're increasing the flow the rate of flow, the velocity of flow progressively as we get to bigger veins, right?
Mm-hmm.
Keep that in mind for something we're coming to in a bit. All right, now here is a formula that is a fundamental relational formula in cardiovascular physiology. You should memorize this. Flow, and we could say cardiac output here, because cardiac output is flow, isn't it? It's the flow of blood pumped by the heart. Is directly proportional to the change in blood pressure and inversely proportional to the resistance. So looking at this, flow goes up as blood pressure goes up, which makes sense, doesn't it? But flow goes down as resistance goes up because these are inversely related, you see here. Now you can rearrange this formula right here and state it like this. A change in pressure is proportional to flow times resistance. We're using the same factors here, but we're just rearranging them. This is a legitimate formula here, isn't it? We just rearrange this. All right? So if the pressure goes up, flow will go up, right? If resistance goes up, pressure will go up on it. So as you increase resistance to flow in the peripheral blood vessels, pressure goes up. You follow me on that?
Yeah.
Yeah. All right, now that brings us to the capillaries. So, capillary dynamics. Now, where did we say that water and solute exchange occurs in the vascular tree?
In the capillaries.
Only at the capillaries. Only at the capillaries. And it does that primarily by diffusion, but applied in different ways. Now, you know what diffusion is. This is movement of a substance, ionic or molecular, from an area of higher concentration to an area of lower concentration. All right. Now this occurs by varied routes. It occurs via our capillaries. It occurs via protein channels in the cell membrane. In fact, most things get through the cell membrane through protein channels. Through the phospholipid bilayer, anything that's fat soluble moves freely through the cell membrane. By vesicular transport, this is the development of little beads, little vesicles that form in a cell and they pop through the cell membrane. It's called vesicular transport. Now, blood flowing into a capillary is under some pressure. We know that by now, right? So that blood is under some pressure. And if we go back and look at our mean pressure chart, from the heart, as we go down through the vessels and into the capillaries, those arterioles entering the capillaries are entering under normal circumstances with a pressure of around 35 millimeters of mercury. All right? And that pressure is going to force some plasma out of the capillary, mainly on the arterial end, because that's where the greatest pressure is going to be, as I'll show you shortly. Now, that pressure is a hydrostatic pressure. Hydrostatic pressure is just the pressure applied to a fluid within a closed system. All right, so think of it as a pushing pressure. It's pushing plasma and some ions and even some small proteins out between the endothelial cells into the interstitial spaces. All right? So, as we said, some small solute molecules will move with the water, ions will move with the water. But what doesn't come out?
The blood.
Large solutes and large plasma proteins. They stay in the bloodstream completely. That's going to be important, as I'll show you in a moment. So as we said, most of the filtration occurs on the arterial end of the capillary. And that blood is going to move through the capillary from the arterial side to the venous side. Because when it comes out of the capillaries, it's going to be on those tiny veins called venules, and it's headed back to the heart. All right? Now, so we have some reabsorption of this fluid that was pushed out by the hydrostatic pressure. So, what gets that fluid back in the vessel?
The osmosis.
It's the osmotic pressure, known as the blood colloid osmotic pressure. That osmotic pressure is created by those large plasma proteins and other large solutes that stay in the bloodstream. So think of that oncotic or osmotic pressure as a sucking pressure. It's going to draw most of that fluid back in to the vessel before it gets out of the capillary into the venules. But does it draw all of that extruded plasma back?
No, it goes in the lymph
No.
capillaries.
What doesn't get back in the blood capillaries gets back to the heart how?
Lymph.
In the lymphatic system.
Yep.
All right. So most of the reabsorption is going to occur at the venous end of the capillary because by that time the hydrostatic pressure has dropped off and the osmotic pressure in the vessel is now greater than the hydrostatic pressure, so it sucks it back in, so to speak. This is an example of that. Now, there are some extra numbers in here that relate to the osmotic pressure in the interstitial fluid and so forth, but I'm only going to concentrate on the main numbers. If you'll take your notes and look at the very last page, you will see a simplified diagram of a capillary model. Now, this diagram is like that model, somewhat. But I'm disregarding the capillary and osmotic pressures that exist in and outside of the vessel, which are negligible. I'm going to concentrate on the main numbers. So let's say that the pressure going in, coming in arterial into a capillary is 35 millimeters mercury. All right? Now, inside that capillary, the osmotic pressure continuously is unchanged. And we're going to give it a number of 25 millimeters of mercury. Now 35 is a higher number than 25, isn't it? So which way is plasma going to move? Out of the capillary into interstitial space. Because you have a net filtration pressure of 10, don't you? You've got a pushing pressure of 35, a sucking pressure of 25 to bring it back in, but the net is that fluid's going to move out. But as you go through that capillary there, that 35 millimeters of mercury pressure is progressively falling. And by the time you come out on the venule side, it's around 18. All right, but what's the osmotic pressure
25.
in the vessel?
25.
It's 25, isn't it?
Mm-hmm.
All right, so 25 is greater than 18. So now the osmotic pressure is greater than the hydrostatic, and so we can suck some of that fluid back in. So you have a net filtration pressure of here -7, don't you? Do you get what I'm trying to show you here? Because I want you to study this and understand this, because I'm going to ask you about it on the exam. Now, that pressure that's pushing fluid out is called a capillary hydrostatic pressure, CHP. Is it labeled for you?
Mm-hmm.
All right. That sucking pressure, drawing fluid back in, is BCOP, blood colloid osmotic pressure.
Is that colloid?
COLLOID.
Thank you.
And that blood colloid osmotic pressure is due to the large plasma proteins and other large solutes that remain in the bloodstream. It's really basically a type of diffusion relative to water, because water moves from an area of higher water molecule concentration to a lower water molecule concentration. Stated another way, it moves from a lower solute concentration to a higher solute concentration. So that's what makes water move back in. Osmotic pressure. All right. Now, venous pressure. Coming out of that capillary, venous pressure was 18, we said in our little example, didn't we? By the time we get back to the heart, the pressure in that vena cava is down to almost nothing. It's down to around 2 millimeters. That's practically nothing, isn't it?
Mm-hmm.
But now let's look back at our little diagram here. When we looked at velocity of flow, we're in the vena cava here.
Mm-hmm.
The pressure is about 2 millimeters of mercury, but the flow is appreciable. Now, what's the explanation for this?
Oh,
Um,
you told us
the
this
radius
last week.
is larger. There's not enough
Because the
pressure.
diameter's
Right, the
bigger of the actual
Aren't the veins getting larger in diameter as
Yes.
you approach the heart?
So you don't need as much pressure to put it through.
So you've got a very low pressure, but you've got a progressively increasing diameter. What's the main determinant of resistance to flow? It's diameter.
Diameter.
Radius.
And so this is why you see this right here, even though the actual pressure is negligible. And this is true, because if you're exploring, you're a surgeon and you were exploring an abdomen for a gunshot wound, and the bullet went in here, so you open the belly and you're looking, you know, you're going to penetrate some bowel, maybe in the stomach, but you're going to follow that on back, and you see that back here behind the peritoneum, there's blood. There's some blood back there, so you got to find out, you know, what the damage is. So you open the peritoneum, and all of a sudden, dark blood just wells up in the wound. That's because this bullet cut the vena cava. That blood's coming from the vena cava. It's not under pressure, it's not going to shoot up to the ceiling, but it's going to well up in that wound because of this right here. The flow is up. All right. What does venous return mean?
Just blood going back to the heart.
Blood returning to the heart. Right. Now, what are the factors that facilitate return of blood to the heart? Well, decreased resistance in the venous side. We've already talked about that. As the heart is approached, the veins are bigger. All right? So that's this here. Valves in the veins. So we have muscle compression that's milking the blood back toward the heart. The valves keep it from sinking back down toward the feet at the pull of gravity. Okay, the respiratory pump has to do with movement of the diaphragm up and down as we breathe in and out. When we breathe in, the diaphragm goes down. The pressure in here goes down slightly. That facilitates the return of blood to the heart. When we breathe out, the pressure that had gone down slightly now goes up a little bit, and so we're sucking, pumping, as we breathe. All right. This just shows you how the valves are situated in different places in the veins. All right, now, let's talk about cardiovascular regulation. Is the flow to every organ in your body the same all the time?
No.
You know, certain organs increase their demand and their need depending on what's going on in the body. All right? And so we have to adjust flow to different organs at different times. If we're exercising heavily, our muscles need more blood. You know, if we eat a meal, we need to divert some blood for digestion and reabsorption of those food nutrients and so forth. Does your blood pressure go up and down all the time because we're drawing blood to different organs?
Within
Or does it
reason.
remain relatively constant?
Relatively
Within-
constant.
It remains relatively constant.
Really?
All right. Now, blood flow is regulated by these mechanisms right here. Autoregulation, neural mechanisms, and hormones. Autoregulation. What you're seeing here is a natural homeostatic response of tissues that have increased needs. So short term, the resistance of flow is decreased and the blood flow is increased when we have a drop in oxygen supply to the tissues or a buildup of CO2, a metabolic byproduct, or a drop in pH. This is homeostatic. A compromised tissue needs more blood. It needs to get rid of CO2 and drop and get that pH back up where it needs to be. So vessels dilate and send more blood to the compromised area. This happens in every area of the body except for one,
The heart.
the lungs. When we get to the respiratory system, I'll explain that to you. And there's a reason for it. Long term, vessel areas of tissues and organs that are starved for blood supply do have the capacity to develop new blood supply, new circulation, branching of vessels. The term for this is angiogenesis. All right, that was autoregulation. Let's look at our neural mechanisms. The control of our neural mechanisms resides in the brain, and specifically in the medulla. So in the medulla, we have cardiac centers that regulate the rate of the heartbeat and the force of its contraction. And we also have the vasomotor centers that regulate peripheral resistance. And this is mediated through the autonomic nervous system. So our cardiac centers, and again we're in the medulla, cardiac centers, rate and force of contraction of the heart. Vasomotor centers, peripheral vasoconstriction. So if somebody, now this happens in compromised states, notice, in most tissues, but not all. Which tissues do we not want to divert blood from?
Brain, heart, brain.
Brain, skeletal muscle. So somebody who has a drop in blood pressure from acute blood loss, pressure drops. We want to get the pressure back up. We have a sympathetic discharge. What does that sympathetic discharge do? Increases the rate and force of the heartbeat. Hopefully that person's going to be attended in a medical facility that will add back some circulating blood volume in the form of IV fluids or tissue expanders or even blood. And the vasomotor centers are going to squeeze down peripheral blood vessels to get the pressure back up. Remember the formula. flow, pressure equals flow times resistance, right? Remember the formula? I can't get this thing to turn off. I tried to stop the whole program, but it didn't do it. So I just had to keep delaying. All right, so beyond those central mechanisms, we have some peripheral mechanisms that are connected to the central control. So we have some baroreceptors. These are pressure receptors. They're located in the arch of the aorta and at the bifurcation of the common carotid arteries. And they are constantly sensing the pressure of blood in those vessels. So, constantly monitoring blood pressure. They're connected via one of the cranial nerves, number 9, glossopharyngeal, to those cardiac and vasomotor centers of the medulla. They have a short-term effect on blood pressure. And this is the way it would work right here, just as you might suspect if you look at the way these work. Now, you might have had your baroreceptors in play at some point, or maybe multiple times. For example, you might have been lying down, and all of a sudden you jump up out of bed, and you're momentarily just a little lightheaded. And then it comes back. What happened, you jumped up right quick, and your pressure dropped a little bit, and your baroreceptors noted this, and they signal your brain to increase the rate and force of your contraction of your heart, get your blood pressure back up, and you're fine, and they went back to their normal monitoring scheme.
What would happen, like with fainting? Does your blood pressure drop with fainting?
Yeah.
And that's what causes you to faint, a drop in blood pressure, sudden blood pressure?
Well, drop in blood pressure will cause you to faint.
Okay.
Because if you drop the blood flow to the brain, it's going to faint.
Is it possible to, like, say if you're feeling like your blood pressure has dropped, and maybe you're at high altitude, if you go to lower altitude, that help to help elevate those blood pressure?
Well, high altitudes are mainly going to affect your respiratory rate. High altitudes are going to deal mainly with hypoxia. Now, your pressure might drop, and yes, dropping to a lower pressure would help that. When we talk about the respiratory system, I'll try to get to that. This is just a simple scheme that shows you down here what happens when your pressure drops. So here is your baroreceptor here. The pressure drops here. You got them bilateral, that they are inhibited. They send the message to the medulla, increases the rate and force of contraction of the heart, increases peripheral resistance. This is a sympathetic effect. And restores your blood pressure to your normal state. It cuts off the stimulation. This is just the reverse way if your pressure goes too high. It does the opposite. This is just a blown up view of what I've just shown you. Now, those were peripheral baroreceptors, arch of aorta, and common carotid arteries. We have some chemoreceptors. Chemo gives you a sense of what? Chemicals. All right, so here, these receptors are sensing oxygen level, CO2 level, and pH in the blood. Now, these chemoreceptors are mainly affecting our respiratory system. We'll come back to these when we talk about the respiratory system. But they have an effect here. as I'm going to show you. So these chemoreceptors are also located right here at the bifurcation of the common carotid arteries. They're very tiny, but they're sensing oxygen, CO2, and pH levels. Their main effect is going to be on respiration. But a related effect is cardiovascular. So notice, when we severely drop our oxygen level in the blood, these chemoreceptors via the brain centers are going to cause an increase in the rate and depth of respiration to get more oxygen in, more CO2 off. As you get more CO2 off, the pH comes up. We'll deal with this in the respiratory system in more detail. But a related effect is cardiovascular, because this also stimulates the cardiac and vasomotor centers that we just talked about to increase the rate and force of contraction and to increase peripheral resistance. So the primary effect is respiratory. A related effect is cardiovascular. Now, something and besides, these central chemoreceptors are also located in the medulla, and they're mainly, you may think that the main thing that drives our respiration is low oxygen levels in the blood. That's not so. The main driving force for respiration is the level of CO2 in the cerebrospinal fluid. As I will show you later, the level of oxygen in the blood has to be significantly decreased before hypoxia is a driving force for respiration. Normally you don't think that. Normally you think it's oxygen, but it's mainly the CO2. As the oxygen levels in the blood drop, they increase the sensitivity of the central chemoreceptors to CO2. Now, when the oxygen levels get low enough, then definitely the low oxygen level in the blood is going to drive respiration too.
What happens
But initially, it's mainly the CO2.
What happens in a case like sleep apnea when they're not exchanging the gases properly because they're not breathing? Is that because of low oxygen that's happening, or does that also have to do with this?
Yes.
Really? Okay. And we'll learn more about that respiratory?
Mm-hmm.
Sweet.
I'm basically telling you about it now. I'll deal more with it about in respiratory. But
is it the same thing that happens when you go underwater and you have that overwhelming desire to breathe because of that? Mm-hmm. The CO2 buildup in the cerebrospinal fluid?
Mm-hmm. Actually, if you're going to try to go as far as you can underwater, and I've done this, and I'm sure you have too. So we do this. We do a lot of breathing, deep breath, in and out, and then finally we take as big a breath as we could. That's really not good. Because what you were doing is you were blowing off CO2 while you were doing that, and making it necessary for you to take a breath sooner than you might have. People have not been known to drown from doing this.
One more question about the sleep apnea. When people have sleep apnea and they don't realize it, they don't have their machines or whatever, they seem to get kind of a little crazy. My father had it real bad, and it was almost like he was high because the CO2 levels would be so high, and that has to do with that?
I don't think so. I'm not an authority on sleep apnea, but
Okay.
I just know that this is a normal mechanism
Okay.
driving respiration. Now, somebody mentioned earlier, too, about when a chronic lunger comes into the emergency room, and they're hypoxic. When a person with chronic lung disease comes in the emergency room and they're struggling to breathe, they're hypoxic, your natural inclination is to slap an oxygen mask on them, right? Well, you have to be very careful about that because this is why. In a chronic situation like that, what happens is they get acclimated to the CO2 levels in their brain, and hypoxia is actually driving their respiration. So if you give them oxygen, you're dropping their own drive to breathe because the chemoreceptors are satisfied because there's more oxygen and saying, well, why do we need to breathe? You can actually cause apnea from that.
Causes CO2
It's like,
Causes CO2 narcosis.
Yes.
that's why with like a COPD patient, they'll only usually give them like 2 liters.
Yes. Yes. Normally, in a person who's hypoxic, you put a mask on them, it's at least 4 liters. Okay, so with a chronic lunger, you want to reduce that because you don't want to knock out their hypoxic drive, because in a long-term situation like that, they've gotten accustomed to those higher levels of CO2 because they're not exchanging CO2 as well. Oops, there's our...
Friendly reminder.
All right, so that's the neural mechanisms. Okay, so we've got our main cardiac centers, we've got our baroreceptors that are tied to our cardiac and vasomotor centers, and we have our chemoreceptors that are mainly related to our respiratory system, but they also have a lesser effect, but connected effect to our cardiovascular state too. So when we get compromised respiratory-wise, we're also stimulated cardiovascular-wise. All right, so hormones. There are some hormones that have a short-term effect on blood pressure, blood flow, and resistance. And there are some hormones that have a longer-term effect. So epinephrine and norepinephrine from the adrenal gland, the adrenal medulla, are examples of short-term hormones. Now, epinephrine and norepinephrine are what we know as adrenergic hormones. In other words, they have sympathomimetic effects. In other words, they increase the heart rate, they increase the rate, the force of contraction, and they cause peripheral resistance in tissues throughout the body, except heart, brain, skeletal muscle. Now, this hormone we'll learn about later, antidiuretic hormone. A diuretic is something that makes you lose water, right? An antidiuretic would have the opposite effect, recover water. All right, well, its main effect has to do with water reabsorption. But in very high doses, it's a vasopressive type hormone. But that's not its main role. Angiotensin II is an important vasoconstrictor. It acts like norepinephrine, but is much, much stronger. But its main effect is not only short-term, but long-term, as I'll show you in a moment. All right, well, now, long-term mechanisms. Angiotensin II. Now, we'll be talking about angiotensin II when we get to the urinary system, because it all begins in the kidneys with this hormone. But we might as well just introduce it right now. In the kidney, there's a location of some particular cells that release 2 substances related to blood pressure flow and oxygen levels in the blood. That particular location, you don't have to worry about now. It's the granular cells in the kidney. But just think of it as blood flow to the kidney. Blood pressure, blood flow to the kidney. As you drop blood flow to the kidney, doesn't it make sense that you drop oxygen supply too? Because isn't oxygen carried in the blood cells and they're under some pressure? Pushing? All right. If blood pressure or blood flow or oxygen supply to the kidney drops, then that certain location in the kidney is going to release this enzyme right here, renin. Renin is not a hormone, it's an enzyme. But it sets in motion a series of events that's going to result in angiotensin II. So here is how it works. The release of this enzyme from the kidney stimulates the liver to release this precursor, angiotensinogen, to form this, angiotensin I. But this is not the active form. 1 has to be converted to 2. And that is usually done in capillaries of the lungs by an enzyme called angiotensin converting enzyme, ACE, A-C-E. If you're in a clinical setting and some people being treated for high blood pressure, one of the things that's sometimes used is an ACE inhibitor. An ACE inhibitor blocks the conversion of this to this. All right. But now what does this do? Now, by the way, this is only going to come into play when there is a significant drop in blood pressure or blood flow. So we're talking about situations where the systolic blood pressure is below 80. This is what you would see in acute hemorrhagic blood loss, for example. So when your blood pressure just drops a little bit when you jump out of bed, does this? No. This comes into play in severely compromised cardiovascular states. But if such a state occurs, this is what happens. Angiotensin II itself is a potent vasoconstrictor. It's about 8 times as potent as norepinephrine. But it also stimulates the adrenal glands to release this hormone. Now, we haven't gotten to the adrenal glands yet, but we will, and you'll hear a lot about this hormone. This hormone causes sodium reabsorption by the kidney. When sodium is reabsorbed, water follows it. Water follows salt. The point is, if we're deficient in circulating blood volume, we want to recover as much as we can, and we want to recover as much water from the kidneys as we can. So this is promoting water recovery by the kidneys. It also stimulates secretion of this hormone from the hypothalamus, antidiuretic hormone. An antidiuretic is something that conserves water, isn't it? So antidiuretic hormone causes water reabsorption from a certain part of the kidney. Don't worry about the details. We'll deal with that later. But if we've got a low circulating blood volume, if we had a low blood pressure, one of the causes is a low circulating blood volume, isn't it? Mm-hmm. So if we can recover water from the kidneys, we hopefully can get that circulating blood volume back up. It also stimulates thirst. Now, is all of this by itself going to make a person in profound hypovolemia recover? Probably not. They'll need some help. They'll need some medical help. They'll need some fluids, right? Maybe a plasma expander, maybe some blood transfusion. And it's going to need to stop whatever is bleeding, okay? Whatever the problem is. That's just one example. Now, look down here at the bottom. Do you recognize this hormone?
Mm-hmm.
It comes from the same place that this comes from. And remember, erythropoietin stimulates red blood cell production, doesn't it? And you've got normally a gradual, continual release of erythropoietin from the kidney to stimulate production of red cells to make up for the ones that are constantly being taken out of circulation by the spleen, right?
Yeah.
All right. Now, if the blood going to that kidney, if its flow is diminished or its pressure is diminished, therefore the level of oxygen entering that kidney is diminished too. Hypoxia stimulates the release of this hormone. What does this hormone do? Increases the rate of red blood cell production. If you're hypoxic, one of the ways you can correct that is to make more red blood cells because they contain the hemoglobin that carries the oxygen, right? So this is a related effect. All right, now let's say that this person with profound hypotension, hypovolemia, brought in from the scene of an accident, he's lost 2 to 3 units of blood and still bleeding, his pressure is down, his heart rate is up, his urine output is down, and so medical personnel are attending to him, giving him fluids. Are we going to go to the operating room? Got a ruptured spleen? Take that out, or aorta's cut, or whatever. You know, stop the bleeding. Get back to homeostasis. Now let's say all that happens. What about our angiotensin II there? Is it going to keep going? Is it going to send blood pressure out the roof? No. No, because we got another hormone that's going to put the brakes on the whole thing. Because as you get blood flow up, as you get circulating blood volume up and blood pressure up, venous return to the heart increases, doesn't it? And now there's more blood entering that right atrium. And that extra volume of blood stretches the walls of the right atrium. And that stretch of those atrial walls releases this hormone right here. See its name? Atrial. Natriuretic, relating to sodium peptide, ANP.
So that's
So,
really...
to remember what ANP does, think of what angiotensin II does. So ANP stops everything. It cuts off angiotensin II, aldosterone, ADH, and reduces thirst. All right, it's just putting the brakes on. Now let's say that this person's circulating blood volume was overcorrected. He's got actually too much fluid on board. Pressure's up higher than it needs to be. This hormone is going to correct this. Because besides stopping everything that angiotensin II does, it's going to increase the filtration rate in the kidney and will cause the kidney to diurese any extra water and get rid of any extra sodium on board too, and get that blood pressure back down to homeostatic levels. So that's basically what this hormone does. This is just a flow chart that shows you this for angiotensin II. Now, the one thing that's not shown on this chart is the effect of ADH. But you can look at this chart in your book. Now, this one here is kind of a busy diagram, but it's just showing you the homeostatic responses to blood loss. What amuses me when I look at this chart here is the example they're giving is a little cut on the foot. Which doesn't make sense to me, but I guess that's the best they could do with the diagram. But you have to lose a lot more blood than that to get all of this going on. So as I told you, we're talking about severe insult to the cardiovascular system. Blood loss, drop in blood pressure. But notice that our baroreceptors and chemoreceptors come into play. I'm trying to find here, well, here's the sympathetic discharge right here. Sympathetic discharge will also set that renin-angiotensin II cycle in process. So, drop in pressure, flow, or even sympathetic discharge will start that renin-angiotensin II mechanism. And that's sort of shown for you right in here. So you can spend a little time with that. And you can see those things coming into play that we talked about. Circulatory shock. Again, is characterized by low blood flow, low pressure, and actually an inadequate blood flow. What are some causes of circulatory shock? I've been giving you the example of hemorrhagic blood loss, but severe dehydration will do the same thing. Massive burns will do the same thing because of this massive fluid loss. It's going to drop circulating blood volume. The main thing that acute burn victims die from early is cardiovascular collapse. The main thing they die from later, if they survive the initial insult, is sepsis, infection, overwhelming infection. Now, will damage to the heart cause circulatory shock? People who present in the emergency room with an acute myocardial infarction, they tend to have a normal blood pressure? No. What about external pressure on the heart? This word right here, cardiac tamponade.
Does that do with the fluid?
What does that mean?
Doesn't that have to do with the fluid?
Pericardial sac. Too much fluid in the pericardial sac.
It's fluid in the pericardial sac accumulating and pressing on the heart. Now, I showed you a pericardium, didn't I? It's very thin, isn't it? But it's very tough.
Okay.
It doesn't distend very much.
Okay.
So if you get an injury to the heart, that ventricle is pumping blood into the aorta, but it's also going to be spurting some through that cut into that sac, isn't it? And eventually there's going to be enough blood in that sac that it starts to put pressure on the heart. What's going to give first? The pericardial sac or the heart wall?
The heart wall.
The heart wall. And so that blood accumulating in there squeezes down on the heart and reduces its ability to fill with blood. And if it doesn't fill with blood, it can't pump much blood. And so these people are going to quickly go into profound shock. And if you don't relieve that pressure, get that blood out of that sac and close the hole, they're going to die. It happens real quick, and you've got to move fast. Now, it can also happen at a slower rate. Say in a myocarditis, they get a pericardial effusion. Now, you can draw that off with a needle, and sometimes you can even draw blood off with a needle. But if it's accumulating fast, needle aspiration is not going to be good enough.
What would make it accumulate fast? That'd be assuming they were in some type of like car wreck, some type of injury or
Gunshot wound,
gunshot wound.
stab wound.
Is there anything like people just as they get older and have stuff go wrong? Is there anything that could just happen to where they start getting that fluid in there?
Not usually unless there's a myocarditis or something like that.
Okay.
So, if that can happen from the fluid, whenever I watched that heart surgery, they didn't sew back up the pericardial sac. Wouldn't you worry about a cardiac tamponade or whatever?
They don't bother with sewing up the sac, do they? I don't think they usually do. You don't have to.
So they wouldn't get that though? You're not gonna get the fluid in there? Because I mean, it's like halfway on there, but.
Actually, if they sewed it back up, I think there'd be more risk of getting fluid in there than if they didn't sew it
Getting
back
it
up.
trapped in there.
That's probably why they don't. One of the reasons that they don't. Now, what about if we have a situation where we get massive peripheral vasodilation? To get the pressure up, you squeeze down on the peripheral vessels, don't you? You vasoconstrict. What if you had a massive relaxation of the smooth muscle in peripheral arteries? What do you think that will do to the blood pressure? Isn't blood pressure equal to flow times
Yeah.
resistance?
Yeah. So
If you drop resistance massively over here, is
Yeah.
that not going to drop the blood
Yeah.
pressure over here?
Yeah.
Yes, it will. So this would occur in something like an anaphylactic shock. You know, acute systemic allergic reaction to something like a bee sting. Now, what are the signs of circulatory shock? Somebody comes into the emergency room in acute circulatory shock. What are they going to look like?
That's,
Huh?
they're gonna no color. They're gonna look like they're about to pass out. Yeah.
They're going to be pale. Why are they going to be pale?
Because they don't have the blood going through. Yeah.
What? Hypotensive, no blood pressure. But what about those peripheral vessels? Didn't they squeeze down to try to get the pressure up? Peripheral vasoconstriction. Of course, they've lost blood. That's true. You know, so they got less oxygen carrying capacity. But those peripheral vessels have constricted, so they're pale for those reasons. All right. Their skin is often clammy. Why is that?
We talked about
What
this last
causes
week.
sweating?
Sympathetic.
Sympathetic discharge. Don't they have massive sympathetic discharge?